Oh, there we go. There we go. I'm here. Just want to make sure. Let me go. Okay. All right. So, welcome everyone to my end of the year live stream. Oh, you can see my messy desk. Oh, well, I am in my office and I just wanted to kind of have a low key chat live. Um, and answer questions for you that I'm able to answer. I am doing this all by myself with the assistance of one family member who is the checking the comments for trolls. Trolls would be people who just want to say mean stuff just for the sake of saying mean stuff, and we don't need that. So that's what's happening there. So do I have this? Let me see something else. I got this banner thing on here. Let me see if I can get this off. So again, there we go. Let me hide it. There we go. My assistant is on vacation because of the holidays. And the other company that I used to help me with this last time, another vacation issue. So I'm on my own. So just that's a heads up that it's not going to be all polished. Okay, well, let's get going. Wow, I see there's been a whole lot of chat happening before we even got started. So I will be just kind of randomly picking questions, especially ones that I can kind of easily read and answer. So keep that in mind when you are asking your question, to try and keep it brief, so that I'm not trying to read a whole screen full of text. All right, so I'm going to show the question. There we go. So I'm going to read it out loud. Thanks, Melody, for your question. During PMS, my symptoms of mania, though mild, appear. I'm on lithium and I have been quite stable. So when this happens, it's apparent and a little uncomfortable. Any suggestions to ease these symptoms? So PMS, it's kind of one of those little tricky topics in that we used to call it PMS, premenstrual syndrome, just this kind of vague sense of before your period, you get moody and things like that. Now it's called premenstrual dysphoric PMDD disorder, which is a little bit more of an official titling, but that's not neither here nor there. I just had to add that, but I'm assuming that's what you're talking about. And let's see. And you can have an elevation of your mood. You can also have more irritability. Patients that I've treated with it, who also have bipolar disorder, tend to fall more on the irritability side when the mood becomes unstable. But okay. You say that any suggestions to ease these symptoms? So really, it depends on what the symptoms are that you're experiencing. And sorry to have that be, it depends. Unfortunately, a lot of things in medicine depend. But here's what I mean by that. So even though antidepressants are usually not recommended for people with bipolar disorder because it could destabilize you, with PMDD, the recommended treatment is a very low dose of an antidepressant, serotonin enhancing agent, I believe 2 weeks before your period is set to start. I think I have that right. So that means you got to kind of keep up with things and then stop it once your period starts. Okay. A lot of people find that intermittent dosing hard to control or hard to keep up with. And so they may just take it the entire time. But I'm bringing that up to say, kind of putting in a little bit of, say, something like Lexapro or something very low dose Prozac, even though Prozac lasts a long time, just during that 2-week period may be enough to ease some of the PMS or PMDD symptoms for you, especially if the symptoms err on the side of irritability or depression. If it's more elevated mood, then you don't want to use an antidepressant. And there really isn't something you can do in terms of what can I take, except something that's sedating or calming. I've had patients where I may prescribe a very low dose of quetiapine, low dose meaning like 25 milligrams, kind of a standard dosing for someone who is taking it to control their bipolar disorder, may be on the average of 300 to 400 milligrams, maybe even 200. So something like 25 or 50 milligrams, they may take to help them sleep. So that you could, so in times of like your mood elevating some, you could take a little bit of something like that. Doesn't necessarily have to be quetiapine, but quetiapine is sedating and slowing. And you could just, and the good thing about the antipsychotics is they work fast. So you could just take it as needed like that for a few days while you're having these mild manic symptoms. And then when they go away, stop. The downside of Seroquel, and just be the last thing I say about this, is it can cause weight gain. And I'm not sure if it's dose dependent, meaning the more you take, the more weight you gain. But I've seen people who, even with the 25 milligrams, feel like they gain a little bit of weight. So that would be something to be careful about. And there's other antipsychotics. I have someone who will add in a little bit of Abilify, if they start to get elevated for whatever reason. And then as soon as it passes, they stop taking that and go back to their baseline meds. So you can stack mood stabilizers to handle a moment, a temporary shift or change in your mood state. Okay, thank you, Melody, for that. Remove you. Thank you so much, Maxwell, for your super chat. I'm so used to saying super thanks. Let me see if I can put your question on the screen. I can't. And I can't hide Melody's. Okay, there we go. Let me see if I can put Max on the screen. I can't. Okay, so Maxwell, who you can't see, but says, I've overcome psychosis, now living with bipolar disorder. My mind is sharper. Very good. I earned an HR certification, human resources, I'm assuming you mean. I'm saying that for everyone else's sake. And with medication, I'm doing well. Thank you for all you do. Okay, great. Thank you, Maxwell. I'm so glad that you're a great example of how you can still be very functional with living with bipolar disorder. And even, you had more psychotic symptoms with yours. It's interesting. So having a mental health disorder does not have to mean it's the end of your life or that you can never be productive. I happen to be watching Homeland right now. I'm late to that game. It came out in like 2011, but Netflix just served it up to me. I started watching it. And the main character on there has bipolar disorder. And there's some pretty accurate depictions on there. And then there's some, Hollywood versions of it. But still, it's, and unfortunately, people treat her as though she's not competent to do her job because she's got bipolar disorder. So, but she's actually very competent. So anyway, thanks for that testimony, Maxwell. And I'm so glad that you've got your certification and you're doing well. Okay, let's see. Let me keep going. So this, I'm going to do this question because this issue kind of comes up for me. I'll get emails about it and sometimes comments about where can I find, someone to treat me for XYZ. So this person says, where can I find an experienced, minimum 10 years qualified psychotherapist in New York City that accepts Medicaid? I've been looking for the past 6 years. All I get is LCSW, that's licensed clinical social worker recommendations, and they're useless. Okay, so my freelance life. I would say that, first of all, okay, if it's your opinion that the people you ran into that are social workers aren't very helpful. That, I'm not doubting that that's your experience, but I just want to say for the record that social workers and master's level therapists can be very good therapists. In fact, better than some psychiatrists who don't do a whole lot of therapy. I trained in New York City, where therapy was a heavy emphasis in my training program, but that's not everyone's experience. It's covered in residency, but many psychiatrists don't want to do it, and so they don't do it, so they're not good at it. And especially when you start getting specialized types of therapies like trauma therapy, you want to see someone, this isn't your question, but I'm just saying for everyone else, you want to get, someone who has experience doing trauma therapy. Well, a licensed, a social worker or master's level therapist can get good at doing trauma therapy, or any kind of therapy for that matter, if they do it enough. So I wouldn't necessarily discount someone's qualifications because they're a therapist, not like a psychologist, PhD, PsyD, or MD. So that's one thing. And then Medicaid, okay, that's a very tall order to get someone who's doing 50 minutes of therapy with you accepting Medicaid, because Medicaid will probably pay them $20. And good luck getting someone who's put all that into training to get $20 for an hour. I mean, they're just not going to do that. So, I think that's unlikely. But another thing about finding therapists, and this is the general lesson for other people, is clinicians are required to have licenses in the state where you live. So if you see a clinician online that you like, you can't, and you want them to be your doctor or your clinician, they can't unless they have a license in the state where you live. And it's not about, proximity. Yes, there's online treatment and online therapy, and there's remote treatment, but the person still has to have a license in your state. So I usually point people to psychologytoday.com. I used to have a listing on there when I was first starting in practice to get people, but and I don't anymore, but there's a lot of information on that site. Like, people are putting their best foot forward, trying to give you an idea of what kind of treatment they do. And if they have websites attached, you can also go to their website and check them out and get a feel for them. So I would suggest looking at psychologytoday.com, and you can search by your state, and then you can see what insurances they accept. Okay, thanks for that question. All right. Let's keep going. I've got another super chat here. I'm prioritizing the super chats. So Chris, I'm sorry, Chris, I can't figure out how to put these on the stage, but Chris KH Rise says, I'm donating this money because you have helped me survive difficulties with migraines created by cortisol levels caused by stress. Interesting. You helped me a lot, and I want to donate more. I also recommend you to my mom's book club. Thank you. You must be in the UK. Your mom. I love that. Thank you so much. I know earlier I was talking about medication, and that's something you can only really get from someone prescribing you or treating you that way and writing prescriptions. And not everything can be handled by self-help, but I do believe education is the cornerstone of wellness, whether it be mental or physical. And the more you understand yourself, the better you're able to take care of yourself. And that's why I do this. And I'm so happy to hear that without me even needing to write you a prescription, just helping you understand things was enough to make a difference. And that makes me happy. Thank you. All righty. Let's see. Let's see here. Still going back to the super chats. Lots of questions. Oh, and then K-Rise. Okay, one more. Can you give a simple self-talk that worked for you in the morning that I can try? I have an autistic child and the holidays are really hard. Wow. Okay. So when it comes to, self-talk is very personal. And what I say to me, or what I say for myself, may or may not resonate with you. So it really is about trying to dig deep to see what it is that pains you and what it could look like if that pain were not there. Let's just say. So I'm speaking very generally. So let's just say you mentioned that you have an autistic child and holidays are really hard. I would recommend, instead of trying to find something fancy to say, focusing on a state of mind that you want to possess. This is just one thing you could say. So let's say you run out of patience with your child because it's just really hard and it wears you down. You could wake up saying something like, I will have the energy to get through the day, or I will be able to manage my responsibilities and have time for myself at the end of the day, or something like that. I'm just kind of shooting from the hip here, but essentially you're looking at what's your pain point. Is your pain point that it's a lot of work, you're doing it by yourself, let's just say, and you just feel overwhelmed. But it's something you got to do every day because you love your child. Then saying something along the lines of you're kind of manifesting. I kind of actually don't like using that term, but anyway, you're kind of like embodying the concept that you've got this. It's hard, but you can do this because you're going to make the best of the energy that you have. And when you run out of energy, you're going to let yourself take a break, and that's okay. And you will restore, and then you will start over tomorrow. So that's one thing I would suggest, to focus on self-encouragement. Oh, and one more thing, removing self-criticism could be another focus of your self-talk, because often when we are doing a lot, I mean, I'm a caretaker too. I get the caretaker burnout. It is for real. Giving yourself, it can be easy to be critical of yourself for not doing enough. And if that's an issue, of giving yourself a break and encouraging yourself early in the morning, first thing in the morning, that, you're going to do all you can do. You have limited capabilities, and that's okay. All right. I wish I could put these questions or these on the screen, and let me see if I scroll, if I'm able to do that better. Let's see. I cannot. All right. So sorry, guys. Be patient with me. I actually want to do more live streams in 2026. With all the AI out there and stuff like that. I don't use AI to recreate myself in terms of like video stuff. I will use it to edit and create thumbnails, but not like, not take myself and, create a video of me, and hopefully no one's doing that of me. But I think it's even more important, as we keep going with this, that people see the real person. So I kind of want to be present a little bit more that way in 2026, but I will have more help next time, so we won't have these technical difficulties. Okay. Let's see. Here's a medication type question. See, it works when I click this way, but I can't click on these super chats. I'm so sorry, guys. All right. If my anxiety, Ellis says, if my anxiety is minimal, could buspirone be worsening my depression? The depression is minimal also, and I'm not taking any antidepressants either. Could buspirone be worsening your depression? Only as a what's that called? I'm blanking on the word right now. I didn't finish my coffee this morning. That's the problem. Paradoxical. That's the word I'm looking for. Only as like a paradoxical reaction. It's buspirone is a serotonin agent. It's a serotonin agonist, meaning it promotes serotonin not through a reuptake pathway like Prozac, Lexapro, Zoloft. Those are serotonin reuptake inhibitors. So you increase serotonin by blocking their re-entry back into the cell. Buspirone enhances serotonin by activating receptors to pump out more serotonin. Okay. It was designed to be an anti-anxiety agent, just as the SSRIs also help with anxiety as well. So, serotonin helps with depression and anxiety. So I would not expect buspirone to make depression worse. It could be that it's not adequately treating your depression that you have, and that you need a separate antidepressant for that. That could be, if you're, depending on, again, excuse me, I got to get this. Oh, I can mute my, right, learn something else. Okay. So, buspirone, so my guess in this scenario, Ellis, is that if you are having significant enough depressive symptoms, that it may just be that you've got an untreated depression that is not responding enough to buspirone, because buspirone really isn't a great antidepressant. It really is. It was designed for anxiety, and that's its target market, or that's its target condition. Can it help with depression? Back in the day, actually, before we had so many augmenting agents, we call them, stuff that you add to your antidepressant, buspirone was one of those. It's not quite as popular to use it that way, to add it to another antidepressant, because of the risk of serotonin syndrome and having too many antidepressants on board like that. But so anyway, yeah, working alone, it just may not be treating depression versus it making it worse. Okay, thanks for that question. All right, let's see. Boy, the time flies. I targeted this for an hour. Okay. Let's see here. Okay. Here's another one. English, dare you. Where do you all get these names from? I'm always interested when I see something like this. Okay. Anyway, I, or if, not sure, was diagnosed with OCD, obsessive compulsive disorder, and later found out I have hyperthyroidism. I was prescribed Zoloft, now at 200 milligrams. My anxiety is better, but it's still there. Can those conditions mask other symptoms? So hyperthyroidism, the short answer is yes. Hyperthyroidism, I don't know if I'd say mask. It could worsen OCD type symptoms. So here's kind of my thoughts about this. So there's OCD, obsessive compulsive disorder, which is really an anxiety disorder. It got recategorized in the latest edition of the DSM under compulsive disorders now, but it's still anxiety driven. And so you can have kind of like a mild version of, not the full-blown disorder, like a tendency to be obsessive or compulsive, especially if you become anxious. It's like you turn up the anxiety and this gets worse. I myself have that problem. So I get very anxious about traveling and leaving things behind and not having my ID and blah, blah, blah. And so on those days that I travel, I don't travel a lot, but when I do, I become a checker. I'm checking this and checking my bag and da 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 da. But on regular days, I don't do that. So I wouldn't say I have OCD. I will say anxiety. One of the ways it manifests for me is starting to do checking. All right. So that said, you were diagnosed with OCD. And if you then later found out you had hyperthyroidism, it could be, depending on how much later you're talking about, months versus years, it could be that if it was around the same time, it could be that maybe you had kind of we call it subthreshold OCD symptoms, like that didn't quite kind of rise to the surface. They were present a little bit. You have a tendency to be obsessive or compulsive. And then you became hyperthyroid, and that just turned up the dial on your internal engine. And then it just popped out and became a big problem for you. That's one scenario. Versus they really are two independent entities. It's just that that you got OCD all by itself, full blown. And then later on, when your thyroid started malfunctioning, if you will, or becoming overactive, it drove the OCD symptoms even more. You said your anxiety is better, but it's still there. So OCD is one of the disorders. It's very hard to treat, especially to get it to zero. In fact, I actually don't think it's reasonable to expect OCD to get to zero. Sub-zero or a little before zero would be, pre-treatment, you're checking and checking and checking, or obsessing and obsessing, and have these compulsions, and it's getting in the way of your day-to-day life and activities. And then post-treatment, it's no longer getting in the way of your day-to-day activities, but you still have the occasional, you still have thoughts that you ruminate over or that you have trouble not thinking about. You still have some things that you do. I'm thinking about like contamination, which is very common obsession. Let's say pre-treatment, you worried about things being touched and all this stuff. You had to do all these cleaning rituals. Post-treatment, it still bothers you. Like you couldn't go to a restaurant and see them take your food away without wondering what are they doing with it in the back. Or if they bring it and their thumb is touching the plate, not be bothered by that, but you still eat. Whereas pre-treatment, you would have wanted to just take the food back because you saw their thumb touching the edge of your food. That's just an example. So, still there could be kind of an expected outcome that you've still got some symptoms. What matters most is the degree to which it causes dysfunction for you. Is it keeping you from getting your work done? Is it keeping you from eating? Are you having trouble? Are you late to everything because you're checking stuff? Are you causing social problems with people you go out to eat with because you're always having your food taken back or sitting at the table talking about how this person's thumb was touching, stuff like that. Like that's really kind of where it matters in terms of, should you look to get more treatment or not, or just deal with what you've got? How much of a problem is it causing you? All righty. Thank you for that question. I got to put on my glasses to see some of these. All right. I feel like I am having a hard time keeping up with all these questions. Aggie22 says, this is one of my favorite channels. Thank you for the concise video. How long do you think it might take before reliable clinical testing of neurotransmitters becomes routine? Oh, wow. That's a great question. So the question is, let me just repeat, is how long might it be before we have clinical testing of neurotransmitter levels? And that becomes routine. I don't know about that, Aggie. I got a cough again. Turn on the cough. Okay. So what is on, like, in the near future, or the wave of the future, if you will, is personalized medicine and being able to have more of a create more of a profile of someone's needs and what their vulnerabilities are. I let's just say it could be that you lean more toward or have a propensity toward depression, and your metabolic profile is such that you don't do well with these medications because you're a fast metabolizer or you're a slow metabolizer. So therefore you need lower doses of medications. Like, that kind of genetic testing of liver enzymes is already here. I would say, even though it has been around for at least a decade, it's still not mainstream because there's still like conflicting information about the usefulness or whether it really changes outcomes enough to make it worth the cost. So it's still not widely accepted. And that's been around at least 10 years. I'm just kind of guessing on the time frame. As far as testing neurotransmitter levels, though, that we're talking brain, looking inside someone's brain. I just don't know how we could do that. As far as looking at like functional neuroimaging and seeing activity, maybe there's some kind of way. This is way out of my league. I'm just kind of brainstorming here, but maybe there is some way to quantify the level of activity that you could see on a functional imaging scan, like a SPECT or PET. Don't know, but that would be the only way I could imagine having a setup to be able to measure neurotransmitter levels. But keep in mind, neurotransmitter levels are not the final answer. Really, the meat of this is at the the cellular, the nerve connection rewiring level, and having pathways that are damaged or not fully functional enough to have those pruned out, and strengthening nerve connections between parts of the brain to improve functioning levels. So it's not just about how much serotonin is there and let's measure that. It's more about how are the nerve cells communicating with each other, and getting to the point where we can determine that, and it being root standard. I don't know about that. That might be, I don't know, if I had to guess, at least 10, 15, 20 years in the future. I don't know. But given how long it's taken genetic testing to still like be meaningful and not even be mainstream, that's kind of why I'm saying that. But given AI and how fast things are moving that way, I could be wrong about this. We could have a better way of measuring brain activity in the next, 5-10 years. I'd love to see that. Okay, thanks for that question. Let's keep going. This wasn't Ask Me Anything, so I will address these. Do you watch medical dramas? No, I don't. I have never wanted to watch. I never watched ER. ER came out when I was in medical school, and I was just like, I'm not going to spend all day doing this stuff and then come home and watch more of it. So yeah, The Pit. I know it's a super popular show. I can't make myself watch it. My husband's the same he's a lawyer. He doesn't watch legal dramas. I love legal stuff, but he doesn't because it's too much like work. So yeah, I don't watch medical dramas. Thanks for that personal question. Appreciate it. Oh my goodness. Okay. Should I answer this one? How old are you? Do I want to answer that? I did say ask me anything, right? So how about this? I will say, why do we act like this with age? I shouldn't care. So I am 58 years old. So there, we have it. I'm getting old. I'm past my prime for real. Okay. J100's got a lot of questions, but I'm going to have to keep moving. Let's see, this is a practical question from Miss Lashunda. How do you do if you need a therapist or a psychiatrist? So there's a concept called split therapy, where you could have a psychiatrist doing your medication management, and then you have a therapist who is doing your therapy. And so you would go see the two individuals separately. Generally, you would see the therapist more often, either weekly or every other week, and then or multiple times a week if you're in analysis. And then you see the psychiatrist maybe, monthly or quarterly or something like that. So that's a pretty common medical model to have the split treatment like that, because a lot of insurances don't want to pay for psychiatrists doing therapy. And as a result, then a lot of psychiatrists don't do therapy. So it's very common to have a separate psychiatrist from a therapist. Your psychiatrist whoever you start with, that first person may be able to recommend other people that they've worked with, like the therapist recommends psychiatrists that his or her clients have worked with, and vice versa. You start with a psychiatrist, the psychiatrist may be able to recommend therapists that they've worked with. So but it is, it's two different folks, two different bills. I know it's not inexpensive. Okay, let me keep it going. Juan Lopez has a super chat. Thank you so much, Juan Lopez. Commenting, just to thank you for your great and supportive work. Happy New Year, Doc, and all. Sorry for my English. From Argentina. Thanks for joining us from Argentina. I really appreciate you. Thank you. Okay. This is interesting from Fab 540. How do I help my adult son get a psychiatric evaluation? The Reiner family horror really struck me. Yeah, that is super scary, and that happens. That's a famous family it happened to, but unfortunately, these things can happen. Are not that uncommon. I shouldn't say they're not rare. Let's say that it's not common, but not rare. Okay. So usually what I focus on when this is related to how you even get them in the door to see a doctor, but then as the doctor on the other side, having someone kind of brought in by the scruff of their neck to see the doctor and it wasn't their idea. One of the ways that I try and engage them in getting treatment is focusing on what their pain point is. So let's just say family recognizes that there's some maybe psychosis, delusional beliefs, something's just not right. They said whatever they said to get them in to see the doctor. Then I talk to the person. They're like, there's nothing wrong with me. Like, okay, well, why do you think your family wanted you to come? Because they don't like the fact that I do blah, blah, blah. Okay. So then my focus is not on trying to convince this person that they're psychotic, but it looks like whatever you're doing is causing problems for you. So how can I help you not have this issue that causes you problems? So if we go back to your original question of how do you get your son into a psychiatric evaluation, you got to focus on something that is a problem for him. So let's just say, I don't know the details of the Reiner family. Like I haven't followed the news enough to see like what the son was saying beforehand and everything. But let's just say the scenario is your child is delusional, believes some things, maybe has irritability, or starts to get violent sometimes, or easily angered, like stuff like that, that feels scary. The focus could be something like, well, honey, I think that I know it can't feel good to be this angry all the time. Or or if, let's say, he's not sleeping, why I think it would really help you feel a lot better if you could sleep better. Like, don't even focus on you acting crazy and you need to blah, blah, blah. You don't want to go there, because they're just going to push you away. So you focus on what they're experiencing that is actually causing problems. So the irritability or the anger, getting mad, popping off. I think you could feel a lot better. How about we go to the doctor and see if they could help? If they're like, I'm not seeing a psychiatrist, that's for crazy people. I'm not saying no, they're not just for crazy people. Actually, they help people feel better mentally. Like anything that's with your brain, your head, a psychiatrist could address. And so I'm just suggesting that we go see a psychiatrist, because it just looks like you're mad a lot, and I hate to see you mad a lot. Something like that is what I would suggest, of trying to like pull him into this. I see that you're having this, you're struggling with this, whatever this is. Let's go get help for that struggle. And don't even go down a road of you're delusional and you just don't realize it. Or let's say they're getting ready to lose their job because of whatever behavior. I don't want you to lose your job. And I think you could feel a lot better like that, taking that approach. Okay. Thanks for that question. Okay, let me keep going. We're going to go until 1 o'clock. Wow, it's 12:44. We're going till 1 because I promised my moderator that I would stop at 1. Okay, let me keep going. Let's see. It's hard to just pick. Sorry, I'm trying to do ones that are where I could have a quick answer. Nellie, what topics will you address in 2026? Thanks for asking that. Last year I did resilience, and that's still an underlying theme for me, because I think if there's anything we need that. But this year I'm doing a little bit of a different angle on the science of love. And it's about, the focus is on loving yourself, because I believe if we want to change the world, you change yourself. And so being able to love yourself, and that, I know that kind of sounds vague. We all love ourselves. Well, actually, no, we don't all love ourselves, but there's behaviors and things that we do, thoughts that we have that don't really demonstrate that kind of love for ourselves. But anyway, but yeah, and so focusing on not only loving yourself, but then being able to extend that to other people, because it's hard to extend love and compassion to someone if you don't have much left for yourself. Like if you're already thin in that area, you're not going to have much to give to other people. So, increasing your battery, or juicing up your battery so that you have more output for others, is also part of that concept of love that I'll be focusing on, and just kind of different aspects of that. Now, how long that will go, maybe 3/4 of the year. We'll see when I kind of run out of ideas with that. I do like to plan. So last year I kind of planned out my calendar ahead of time. I didn't do that in 24 and previous. It was just kind of every few weeks I'd like see what I'm going to talk about. So now I'm trying to get better at just being more intentional and planning so that there's some cohesion between some of the things that I say. So, that might be either half the year or 3/4 of the year. It will start the second week in January, because next week I'm going to be talking about kind of a brain reset and how it's just a natural thing for us at the beginning of every year to think about resolutions and how am I going to do things differently this year. And it's a thing we do, but it's not purely social. It's actually brain based. Like our brains naturally want to create a purpose and identity around transition times. So that's what next week is about. And then I will start my love series, assuming life doesn't get in the way and like it did at the end of this month, and keep me from getting all my stuff out. We had some sicknesses and stuff like that. So life lifed for me. Okay. Thank you for that. Let me move you off. How do I move you off? There we go. All right, there we go. Let me keep going. Let's see here. Let's see. Sorry, I didn't mean to answer. So let me just answer this real quick for you. I didn't realize I had just answered your previous question, so I can make sure I get to other people. But is there a psychiatric component to menopause? Psychiatric component. That's kind of, so does it affect your brain, if that's what you mean by psychiatric component versus psychiatric disorder component? Yes, it affects your brain. Yes, there's a mental component to menopause, the drop in estrogen levels and things. Many women can feel depressed as a result during menopause, or even during the transition to menopause with the dropping estrogen levels. So that be kind of hormonally driven. It also can affect your thinking. You're not as sharp. Which is, psychiatric, but it's not so much, it's not necessarily mood related. So, some people can tolerate hormone replacement treatment as a part of their overall health treatment, whereas some women, it's not recommended to take hormones, even though potentially that could help if you started having mood symptoms during menopause. And one last thing, I still consider this a psychiatric component, but can definitely affect your sleep. So chronic sleep deprivation can lead to depressive symptoms or feeling depressed, also having trouble thinking and focusing. Some women can feel like, I think I have ADHD. Well, you might, I'm not going to say you don't, you could, and it just, didn't really manifest until now for some reason. Or it could be that it's not technically ADHD, the disorder, but similar thinking, problem solving problems because of the menopause state that you would see in someone who had it just, I was going to say de novo, that's not right, but had it inborn, had it as its own disorder way before menopause kind of thing. Okay, thanks for that question. Keep up with my time. Okay. Let's see. Happy New Year. Thank you, guys. And Happy New Year to you all as well. I saw another thing. Okay, I think I can now do the super chats over here. Are these ones I've already done? Okay, let me see. Yes, I was clicking in the wrong section. All right. I learned something else. So I'll try and do better next time, guys. All right. Thank you for the super chat. Any insight or recommendation for a future psychologist and student awaiting doctoral admission letters? I have an interview scheduled for February. Congratulations. I would say that. I think that psychology and psychiatry are the best specialties to go into. I'm biased, of course, but because I just think the brain is fascinating. And human behavior is fascinating. But, when you think about it, at the end of the day, this is all we've got is our minds. Like our bodies, if your mind goes and your body is still here, there's not much of you. But if you're disabled in a wheelchair, but you've still got your mind, you're still the person that you are. So, focusing on protecting, supporting, understanding our brains and our minds is everything. Like that's number one on the agenda. Okay. So anyway, so I think it's the best area to go into as far as, so your pathway is a lot different from mine as a psychiatrist in that, I had to go to medical school, and then residency, and that's this whole process versus, say, you said you're awaiting doctoral admission letters. I guess you're awaiting admission to a doctoral program. So that would be like me waiting for admission to medical school. Yeah, I don't know how competitive it is for your programs. So I can't speak to that kind of like angst, but there's no overflow. I mean, there's no excess. We need more psychiatrists and psychologists. So, if you don't get into this program, which, can't see why you wouldn't. I don't know how competitive they are. There has to be a place for you because this is the need. It's a huge need. And it's not like there's too many of us out there. So, the programs don't really need you. But anyway, good luck on your interview. And you're in for a great ride because it's a great area to work in. So best wishes to you. All right. Oops. So how do I hide this? Okay. How much time we got? Okay. Let me keep going. I figured out where the super chats were. I just at the end of the thing. All right. Let me go back over to the general questions here. I'm not gonna botch your name. Can doing meditation lead to psychosis? Okay, I'm gonna say Ishan Gupta, if that's your name. Thanks for the question. Can meditation lead to psychosis? No. So let me explain. Either you're going to be psychotic or you're not. You can't make yourself become psychotic from thinking too hard or thinking deeply. It's not, you can't just manufacture it like that unless you have a predisposition to become psychotic, in which case the meditation in this scenario would be perhaps triggering or something you're engaging in because you're already psychotic. So let's just say, as someone, I'm picturing someone who's, becoming manic and they're also becoming psychotic because it's not the same thing. You don't have to be manic and psychotic, but they're becoming psychotic and they start, kind of thinking way outside the box. I mean, that's one thing about psychosis and psychotic thinking is that people can think in ways that the non-psychotic person just can't even imagine. But let's say you start having these kind of thoughts that kind of go beyond what the average person thinks about, and then you start ruminating on this and like meditating on this, like thinking about it a lot. And then the more time you spend like getting this all worked up in your mind, you just start, your thoughts continue to escalate. Your thoughts are escalating because the illness is making them escalate, not the meditation per se. You just may be meditating a lot because you're already psychotic. So that's my answer to that. Thanks for that question, because I would not be surprised if other people think that. Okay, so this will be my last question. But I do want to say, well, no, hold on. Let me get this off. Where did it go? I do want to, okay, yeah, I'm going to come back to that, but I do want to just say thank you guys. Happy Kwanzaa. Thank you. Greetings from New Jersey. Sorry. New Jersey. Love your content. Thank you very much. Okay, let me answer this last question. I almost hate to go. I think the next time I do this, I'll do it for longer. Of course, I'll have more support too, and I won't be fumbling around with all this stuff. So, I'm extremely depressed, untreated, but managing. Will there be a cure in the future? So the short answer, I like short answers and then explaining. The short answer is no. Not in a future that I could imagine, because, and then I will explain, we usually don't think of medical or psychiatric illnesses as having cures. I know one of my attending physicians in medical school once told me, said, the only thing you can cure is something that you can cut out and throw it in the trash. So, a colon cancer, if you're able to cut it with clean margins and put it in the trash can, you've cured yourself, unless, you have a genetic predisposition for another one to grow. So high blood pressure, depression, diabetes, like those aren't cured per se. I know some people will say, well, I lost a bunch of weight and so therefore my diabetes went away. But if you were to slip back into whatever kind of eating, because I know I'm going off on a tangent, sorry, but if you already, let's say you start your fasting glucose starts to creep up and you're in a pre-diabetic stage, that stage still means that you have some insulin resistance. Now, if you get in shape, you eat better and all of that, and then your blood sugars go back down, you still have some insulin resistance. It's not like that resistance necessarily reversed itself. It's just things adjusted in a way that you're no longer, like your pancreas is functioning enough with what it's got. So in theory, that you didn't really cure diabetes. You just, you've managed it in a way, and you caught it before it got too bad. And now, it's manageable. But, if someone were to do autopsy, take a section of your pancreas and look at the cells, you would still show change that was consistent with someone who started to develop some insulin resistance. Okay. So really you didn't cure. So this is probably too nuanced of an answer, but so with depression, kind of same thing. People can have symptoms that come and go where, you could go years without an episode, but if it comes back, then it wasn't cured. So we don't really think of depression as being cured, meaning the vulnerability that you had, the changes in the brain have gone away, will never come back. And it's just, it's just out of the realm of possibility for you ever again. That's what I think of. That's how I'm defining cure in this context. So if we take out that extreme definition, then it can be managed to the extent where potentially you don't have symptoms for a long time. I know I say this a lot, but I think the closest we can get to that right now or in the near future are psychedelics, my favorite topic. just because of of what they do and how like powerful they are. But at any rate, in terms of the concept of 1 or 2 doses, resolving or not or treating your symptoms and having those symptoms be gone for months, that nothing we have right now works that effectively and efficiently. So as time progresses, could we start to get a hold of agents that work more with our brain chemistry to change our wiring in a way that we kind of overcome these issues better? That's my hope. That's my hope that we get there. And if that happens, it may effectively feel like a cure because it's the treatment is so much better and people stay in remission so much longer, but technically it's still not a cure if you didn't change the brain sufficiently enough to put it back to baseline before you had this problem. Okay, that's probably not I probably got too specific and technical for you there, but I still wanted to be correct. Okay. Thank you guys for showing up. Let me know in the comments if you want me to do this again, if you kind of like this. I do feel, this could probably easily be, I think before when I've done these lives, they've been at least 2 hours. And I'll probably make it that way the next time so I can get in more questions. But anyway, let me know if you're interested in me kind of working some more of these into my regular scheduled programming. And if so, then I will definitely consider doing that. Okay, have a happy New Year. Be safe and be safe this New Year's Eve if you haven't already experienced it, like here in the United States. I saw Australia has already had their New Year's. And yeah, so happy to have you around, guys. And you all make this worth it for me. I love doing this. And I don't necessarily mean the live stream specifically, but teaching on YouTube. I absolutely love it and want to be around for a long time. All righty. Take care. See you in the new year. After I figure out how to stop. Oh, here we go. Okay. Bye.